it's really my pleasure to meet you, and I'm grateful for the opportunity to speak with you today. Yeah.
I'm very happy to be here. Thank you.
So let me briefly introduce our organization. It's Clouds Education. We are a Ukrainian NGO that focused on improving medical education, particularly for medical students and residents. Our team consists of 15 dedicated medical students and residents. And we also have some mentors, like experts, not only in Ukraine, but also mostly in the United States. And we are working on several initiatives, starting from ultrasound training and trauma care education to policy, helping with policy planning and curriculum development for our medical universities. So
Awesome.
the aim is to bring to fill those gaps in medical education in Ukraine. And today's interview is a part of the broader effort of learning from international systems, especially United States system, to explore how we can adapt best practices to our Ukrainian context. And especially, we are focused on improving curriculum design and enhancing teaching methods for our educators.
Mhm.
So we would love to hear about your experiences, especially as they relate to medical education system in the United States and the strategies you use in your teaching. So we have prepared some key topics to discuss, but please feel free if you want to share anything important that is beyond that frames. I'll be absolutely happy to, and we would be absolutely happy to have it also.
Okay.
All right, so to start, it will be great if you could introduce and give us your background. Like where do you practice as a physician and where do you teach as a medical educator?
So I'm Lauren Sigman. I work at Oregon Health and Science University in Portland, Oregon, as an emergency medicine physician. I did my medical school at Boston University and then residency training at USC, University of Southern California, and then came up here to OHSU for a medical education fellowship, and then stayed on after I graduated fellowship to teach here. So now I am clerkship director. So I run all of the clerkships for the medical students for our department. And then I also do a lot of career advising for medical students at the school. And then I run one of the first year medical student courses, their cardiopulmonary and renal course, um, for the first years. And then I work some shifts on the side. So that's sort of what I do.
Oh, a huge commitment. Um,
Yeah.
could you please just you just mentioned the word clerkship. It's something that is like beyond my knowledge. I
Oh
think
yeah.
have that. So could you please elaborate on clerkship? What is that?
That's just the term we use for a medical student like clinical rotation. So students at OHSU, medical students spend their first year and a half in their pre-clinical curriculum, which means that they're just in courses, like in, classroom courses and doing some clinical stuff, but mostly just learning the material in a classroom. And then after that, they start doing their clinical rotations, most of which are a month long. And so each of those month long clinical rotations is called a clerkship.
Okay. And as we just started this topic, could you just briefly overview the path of attending before he or she before them they become attending, like
So
studying for medical
basically,
school, I
you
think.
do, okay, so yeah, so you do like 4 years of college, and then you do 4 years of medical school, and then you do a residency, which depending on what field you go into, can be, anywhere between 3 and 7 years. And then you can do a fellowship after that, but that's optional. Or after residency, you can just go straight into practice.
Hmm. Okay, for fellowship, it's like a more narrow field, like a specialization, like more narrow one, right?
Yeah, like a subspecialty. So, like, you can do a residency in internal medicine and then a fellowship in cardiology, for example, if you want to. My fellowship was a little bit different than most fellowships in medicine because my fellowship was not like a clinical fellowship. It was in medical education. So it was like in learning how to be a good educator. And so that is something that emergency medicine offers, but not very many other fields offer that fellowship. Most fellowships are like a clinical subspecialty type
Mhm.
situation, and
So,
those can be anywhere from 1 to 3 years long.
mhm. So if you decide to go, if you have your residency in internal medicine, you can after completing the residency program, you can go to have fellowship in medical education, right?
Well, I don't think that internal medicine actually offers a medical education fellowship. I think emergency medicine might be the only field that offers that. But if but internal medicine offers many clinical fellowships that you can do. So it just sort of like every field has their own set of fellowships that they
Mhm.
offer after residency training. And so you have options for what you can do after residency. And some fields, almost everybody does a fellowship, and other fields, it's rare to do a fellowship. So it just really depends a lot on what field you're in.
It's interesting that only emergency medicine have this fellowship in education. Do you think it's can be explained with some sort of like why?
I don't know. I mean, emergency medicine in general has a lot of fellowships that you can do from it. And many of them are not are sort of atypical, like are a little outside the box. I think maybe it's partly because emergency medicine is a younger field in the United States. Like it just became a specialty in the 70s. And so it's not been around as long. And so I think we don't have such strict traditions that are set. And so I think, I don't know if that's part of it, but we have other fellowships that are also a little unusual. Like we have administration and we have like global health fellowships and we have, I don't know, there's a lot of fellowships that are not common to other fields that are available from emergency medicine.
Oh, interesting. So it's probably due to the novelty of the emergency medicine as a specialty. Okay, interesting.
Yeah, I think what emergency medicine people are jack of all trades and sort of open-minded to new things. And so I think that I don't know if that's part of how we ended up with like so many fellowship options, but it's nice. It's good for
Okay.
people who go into this field that it's a very versatile field.
Hmm. And could you maybe there is a particular point in this journey of a medic in United States where students typically face the most difficulty?
In like the most difficult phase of training, you mean?
Yeah. Hmm.
I think for most people, the most difficult part of the training process is residency. I think for most people, medical school is hard, but fun and like doable. And then residency is a grind that is very, very hard. And there's variation in that. There's certainly some residencies or some types of residency are harder than others, but I think most people think residency was the hardest part of their medical training.
And That is due to the amount of work that you have, right? To the tough schedule that residents have, or
Yeah. So in the United States, the work hours for residents, I don't know how it compares to Europe, but we have 80 hours is the cap. So 80 hours a week is the cap for resident hours. And you have to have 1 day off in 7 on average, but it just has to average out to that. You don't actually have to have 1 day off in 7. Um, and then um, there's like rules around you can't have clinical responsibilities for more than 36 hours in a row, stuff like that. But these caps are pretty large, right? Like an 80-hour work week is pretty brutal, especially when you're doing that for 5 years, for example. And so, and then while you're working that much, you are making minimum wage essentially, because the salaries for residents are very, very low. So you work a lot. There's not a lot of time for a personal life or for sleep or family obligations. And then during that, you're also making very little money. So it's a hard time. Plus the residents typically, you're the bottom of the totem pole when you're a resident. So you're doing all the grunt work, especially when you're a junior resident and you have to kind of work your way up to having more independence and to doing more of the cool stuff. But certainly when you start out, you're doing a lot of grunt work that is not necessarily the most fun work to be
Mhm.
had in the hospital.
Is there predisposition based on that to residents? I mean, do they usually complain on being um, what's the word offended, right? Um, by everybody in the hospital, like you are the new one, you don't know anything, you're like something like that. Do they experience that, or you try to mitigate it somehow?
I think there is some of that for sure. I think, nurses often have more experience and often more knowledge and like clinical gestalt than an intern does, for example, a first year resident. And so it's a little bit weird because an intern has theoretically, sort of ranks higher, not higher, but like, is in a position to tell the nurse like, okay, this is the plan, this is what we're gonna do. And the nurse may know that's a stupid plan, that's not what we should do, right? But technically the intern is the one who is in the position to like make that decision. And so it can be weird because a nurse who's been working for 40 years and has a lot of knowledge can be in a position where they have to take orders from a person who's been a doctor for 2 months, right? So yeah, there can definitely be some friction. Many, I think many, and then but there's typically a fair amount of supervision. So when you're an intern, you're being supervised by a senior resident and or an attending basically at all times. And so I think most of the time, the more junior residents have discussed whatever plan it is with their seniors, and it is a reasonable plan. And so it's sort of everybody's on board with that because they know it's a plan that's coming from the whole healthcare team, not just this one individual. But I think sometimes in the moment, this one individual junior resident has to make a decision. And sometimes it's a dumb decision because they're a junior resident. They don't know what they're doing. And the other people on the healthcare team could be like, okay, I'm not going to follow what you're saying right now because that's silly. Um, so I think there could be some like instances of that, but I think in general, the system works because it is a team, like there's a lot of team discussion, and the junior residents are often just sort of passing on team plans.
Mhm. What about the public attitude, like from like, on the street, if you hear that the person is a resident, what are the, I know that it's like you cannot say for like everybody, but like from your subjective opinion, if a random American hear that, oh, he or she is a resident, what do they think? What are the thoughts about this person? Is like a respected person or yeah.
I think it is generally a respected person. I think there's variation in in how well lay people understand the training system. And so there is some people don't understand the difference between a resident and an attending. And so they're just, you introduce yourself as doctor whatever, and they're like, okay, this is my doctor. Like, and they don't understand even that you're in training necessarily. We try to always introduce, we like residents are always supposed to introduce themselves as like, I am the resident, but people don't always know what that means, right? Um, there are certainly people who know that you are in training when you are a resident and who are very much less interested in what you have to say as a resident and they want to talk to your attending. I think overall that is rare. The vast majority of people are very happy to work with residents and understand that even if you are training, you are being well supervised and that you're still like a knowledgeable and respected person.
Mhm. Okay, thank you on that. And next, I would like to talk about teaching methods that you use in
Mhm.
the United States, and that's because that's an area we keen to develop in Ukraine. So, what are some of the most effective active learning techniques that you use in your teaching? How do they help you improve students' outcomes?
So, I think the number one best teaching, or learning experience, I guess, that a student can have is just time in the clinical areas. There's no substitute for that. And so I think having time in the clinical areas with the appropriate amount of supervision, which can sometimes be less and sometimes be more, depending on the student's level. But I think like gauging this student's knowledge and skill and then titrating your supervision to that level appropriately. So if they are a more advanced learner, like back off and let them have some autonomy. I think that is the number one best way students learn. But short of that, so and that's why we have them spend so much time, like 2.5 years in our school's curriculum, is just on clinical rotation so that it really emphasizes that clinical experience. But beyond that, we also have I mean, obviously you have to learn the material at some point. And so as first year medical students, they have a mix of learning methods that do include lectures with PowerPoints, sort of like your standard traditional format, but also small group discussions and patient panels. So sometimes students will learn about a disease and then that person giving the lecture will bring in a patient who has that disease and the patient can talk about their experience with that disease. And I think, is a powerful way that it sort of makes it more personal and more, I don't know, I think it makes it stick in their brain better when they hear a patient talking about their experience with this thing rather than just learning PowerPoint slides on it. Um, and while so that's sort of the initial part of the curriculum, is like lectures with small group discussions, some patient panels, and then also some early clinical experience. So very heavily supervised time in the clinical areas with a preceptor in those very initial years. And they also have some standardized patient encounters. So they will um, in a small group setting, they'll learn physical exam maneuvers and techniques. And then at the end of that semester, they'll have an exam, where on a standardized patient, they'll have to do an interview and perform those elements of the exam to sort of show that they can do that. So that's the early part of the curriculum, like the first year and a half. And then they take their first huge standardized test, which is called step one. That's at the end of that year and a half preclinical period. And then once they pass step one, they move on to the clinical curriculum. And I think in those clerkships, it's, obviously the vast majority of their time is spent in just working in the clinical areas and gaining knowledge that way. But they also have some didactic sessions where they can have lectures. Simulation is heavily used at our institution, so students can have more of a leadership role, or can, experience some element of that field that on a real patient they're not ready for yet, but in a simulated environment they can have a larger role. That's a big component of the curriculum. And then they, for example, in emergency medicine, in our rotations, we use ultrasound a lot. So we do an ultrasound workshop, and then we have students go around the emergency department with an ultrasound machine and one of the senior residents, and they just do a lot of hands-on scanning time to just get practice with it. We also do a suture workshop with them so that they have some experience with laceration repairs before they go off into their rotation, so that if laceration repair opportunities come up, they are well situated to take advantage of those. Yeah.
Okay,
Does
that's
that answer your
yeah,
question?
yeah, absolutely. That's a lot like an overview. Then I have some small questions based on what you just said. So you said that lectures are used like standard PowerPoint. Is there any insights, like maybe there are some better versions of lectures, worse versions of lectures for medical students? Like, do you heavily use images of patients, or maybe just bullet points, or yeah, any insights on the better versions of slides for students?
Yeah. Yeah, so there are definitely ways that you're like supposed to make a PowerPoint to like be a better presentation. One of the challenges of our medical school curriculum, and I think many medical schools are facing this, is that students are not required to attend class in person. And so all the lectures are recorded and posted and available for students to watch the recording if they prefer to do that. And a lot of students like to do that because then they can watch it on like 1.5 times speed, so they can like watch a faster version and sort of get that knowledge faster, because medical students are all about efficiency. And so I think, and plus they can do it from home or whatever, so it's convenient. And so not all students like watch the lecture, so that is a caveat that complicates it a little bit, but the ideal PowerPoint lecture, I think, is one that is still very interactive. So um, I think having some element of questions built into the PowerPoint that check the material that was just taught. So like you teach a topic and then you quiz on that topic, and it sort of incentivizes students to pay attention and like follow what you're saying, because they might be called on in a few minutes to answer a question on this thing that you're currently talking about. And it should be easy questions, right? It should not be like difficult questions, but easy questions that quiz the topics that you just taught. And there's different ways to do it. You can just call on people randomly,
Mhm.
which is nerve-wracking for students, but it is an option. You can have people volunteer to answer questions, but then you end up getting the same few people volunteering over and over again, whereas everybody else just like doesn't engage. So I think that's less good. I personally prefer the method of having like a little toy. I'm trying to think where I have it. Hold on, sorry. I have it over here somewhere. A little I have a little stuffed animal that I can't find right now that is a little heart and lungs, like stuffed animal. And students pass that along, and whoever's holding the stuffed animal is responsible for answering the next question, you know? And so I like that method because they just pass it down the line and they know when their turn is coming. So they have some warning, but also it forces everybody to participate. So I personally like that method. I have some example PowerPoints I can show you if that like is helpful at all. But I like sort of having that element of interaction and that element of like, okay, I taught you this. What did I just teach you? So it's like sort of like a repeat back almost
Mhm.
method. There's also, you know, typically best practice is to have less text on your slides. Like you certainly don't want a wall of text. You want some visual interest, right? So images or videos or whatever, I think can be really helpful. There is a trend towards having only images on your slide. So like your slide is like just one big image and you then speak, you know, say whatever your points are, but they're not written on the slide. And I have sort of mixed feelings about that. You know, there's research that shows that if you have a bunch of text up on your slide, people will read the text and not listen to what you're saying. So I think there's definitely a disadvantage to having a lot of text on your slide. But on the other hand, if you have no text on your slide, I know from personal experience, if people zone out for a minute or two and then they come back and they start trying to pay attention to, there's no text at all on the slide, then it's really hard for them to get like to understand what you're talking about or like catch up on that couple of minutes that they lost. I know because I frequently zone out for a couple minutes at a lecture and then I come back and then, you know, it's like helpful to have some text to know like, okay, what did I just miss? So I personally take sort of an in-between tack where I have bullet points that are like brief bullet points that show up one at a time. So that way people aren't reading ahead and, you know, not paying attention to what I'm saying. But as I talk about a bullet point, that text, that bullet comes up and
Mhm.
it's brief. But it that way if people zone out, they come back, they can see, all right, what are the last, you know, 2 minutes of material that she said with mixed in with images. I think is like the happy medium between those two extremes. You certainly see people who make their PowerPoint slides and it's just like a wall of text. And I think that's really unfortunate. But some people like old habits die hard, you know, but we definitely encourage people to use more images, to use briefer bullet points and have them show up one
Mhm.
at a time. And then the most important thing I think is to have some element of active learning. Um, and you know, that can be breaking people up into small groups. Like, okay, here's a topic now, like break up into small groups and discuss what you think about these three discussion questions. Or it can be like what I said, like, okay, here's what I taught you, like answer a couple of questions on this. There's also a poll system that students have access to. So uh, in the first year and a half of the curriculum, people often will include board style questions. So like questions from that big test that they have to take, step one, um, inserted throughout their lecture, and students can like go on their phone and put in an answer anonymously, and then the poll shows up on the screen. And so you can see how much of the class got the question right. Um, and that sort of encourages participation and is some active learning, but is like anonymous still and like low stakes for students. So they're not feeling so nervous with it. So that's another common method that people make it a little bit more active.
Yeah, that's a cool method to engage even online if you are like in Zoom, you're presenting the slides to have that
Yep.
poll. You can run it online, I
Yep.
think, and you just
Yep.
engage and see how many students track what you're saying, how many, cooking something in the kitchen while
Right.
you
Right.
muted. Okay. So
Yeah.
that's helpful. That's really like we will take a note on that. And about simulations, I know that it should depend on like the medical school and on maybe how equipped this or that medical school is. But what is the general like mannequins and um, materials that you can find in the simulation? How it is it simulation center where you just go and there is like rooms
Yeah.
with different materials? But yeah, tell me about more about this stuff.
So, here at OHSU, we're lucky to have a really nice simulation center that we have available to us. You have to like book it and you can't book unlimited sessions. So it's like somewhat limited resource, but we, for example, for our emergency medicine rotations, we have simulation for the students once a month. And the mannequins are pretty, they're nice mannequins that blink and their pupil sizes change and they have respirations that you can count and they have a pulse that you can feel and you can listen to their heart and you can listen to their breath sounds and all that good stuff. You can do procedures on the mannequins, so you can start an IV or put in a central line or whatever. You can intubate them. um, if you're doing CPR on the mannequin, the person at the computer in the control room can tell if it's high quality CPR or not.
Mhm.
They can tell if you've intubated the esophagus or the trachea, so it's like and you can also change, like if the mannequin's hooked up to the monitor, you can obviously change the vital signs, you can change the rhythm that's showing up, all of that, stuff. So
How
it's
and
a
how
really
is the work?
nice.
And how is the work organized with this center? Like students can attend by like filling any forms, or it's a part of like curriculum they have to go there, or yeah, or what's the structure? How they attend those simulation centers?
It's a part of the curriculum for whatever course they're in. So I think many courses, not all of them, but many courses involve some simulation component, and it's something that the teachers arrange, like the whoever's running the course arranges it, and the students are just given a day and time to show up to the simulation center and they do whatever activity is planned there.
Hmm. Is there a difference in the how much time you can spend, like how much time you will be allowed to spend in simulation center, depending on what teacher you will get? Like some teachers may let you have more time there, some just maybe won't tell you like, ah, it's unnecessary. Don't pay attention to that. Do you have that problem?
No, because the curriculum is standardized for every person. Every person coming through that course will do the same curriculum. So, and will spend the same, if there is a simulation component to it, they will spend the same amount of time in the simulation. So it's pretty standardized.
That's a cool thing. That's a really cool thing.
Yeah.
And okay, so who is in charge if something will go wrong with the mannequin, if something in some if somebody will damage it or
So there is a person, so usually there's like a control room, right? Where like we can see the students, but they can't see us. And so we're watching everything that they do. And there's usually like the educator who is responsible for that scenario in the control room, and also one of the techs from the sim lab, who are, they're the ones who know how to like work the mannequins and stuff. And so the techs are pretty protective of their mannequins, and so if the students start doing something crazy, they'll stop them most of the time. But I'm sure mannequins do get damaged or whatnot through the course. That's just sort of, gonna happen in the course of being used. And so that is something that the sim lab, pays for to have repaired if something accidentally happens to it. So it's sort of, I guess, up to the educator and the tech to make sure the students aren't doing anything
Mhm.
too crazy. But
Okay. Okay, so as I understood, students have some curriculum. So if they have a emergency medicine block, they uh,
Mhm,
they should go through some practical skills that they should acquire, right? And one of them can be like intubation, and they
mhm.
have to like all students will go through the simulation center, putting tube into trachea, right?
Mhm. Yeah,
Mm, that's cool.
exactly. And it's just, and it's like mostly in the clinical phase, mostly 1 month courses. And it's like one faculty member who's running that course, and it's just the same 1 month curriculum that runs over and over and over again. And every student coming through that curriculum will get essentially the same experience, going through whatever skills they need to do.
So, and students on their first years in medical school, they have several different lessons, like I mean different subjects each day, or it's all blocks as in residency. Like it's a block of
So
emergency medicine, block of cardiology, whatever.
It is all in blocks for the most part. So in the preclinical curriculum, they'll have um, their sort of have different courses in a day that they'll attend. But once you get to the clinical curriculum, then it is 1 month blocks, usually 1 month, sometimes 8 weeks, but 1 month blocks, and that you're doing that one thing full time. And that's usually like between 50 and 75 hours a week or something. And it's just that one block that you're working on.
Mhm. And how do you evaluate students for the practical, theoretical parts? Like, what are the standards for evaluation, except step one and step two?
So the preclinical phase, students have exams at the end of each of their blocks that they have to pass in order to move on to the next one. And all of it is pass fail. So we don't have grades other than just pass fail. And that we have exams that are our own exams that like the directors of each block write. And then there's also exams that are practice exams for the step exams that are questions from those, like from that bank of questions provided by that board organization. So there's two types of exam after the blocks. There's like our own exam, and then there's that national board practice exam, if that makes sense.
It's usually
Um,
tests or open questions or what's the format?
no, it's like it's closed book. They have to do it, they have a certain amount of time that they have to do it in closed book. And for
What do you
both of
mean by,
those types of
sorry, what do you mean
exam.
by closed book?
It means like they can't use outside resources during the exam.
But it's ABC testing or
It's multiple choice. Yeah, sorry, it's all
yeah.
multiple choice.
Okay.
So
Uh,
that's the exams, and then plus they have those practical exams I was saying with like the standardized patients where they have to demonstrate that they know how to interview a patient and that they know how to do a physical exam and stuff like that. So those are the types of exams they have early on. And then in the clinical phase, some rotations have exams at the end and some do not. And the ones that do, some of them are written exams, and some of them are the clinical practice with a standardized patient. So it just kind of depends on the rotation, what type of assessment methods they use.
mhm. Okay. Um, All right. And what is the typical student's motivation to like how do you think they are motivated to stay like to be active in learning, to engage, to participate through all those years in medical school and residency? Is that because of the cost of the education? Like they have to pay a lot, so they they like feel that they have to put a lot of efforts into what they pay for, or are there any other maybe um, benefits or things that motivate them?
Yeah. I think a lot of it is just um, wanting to succeed at this thing that they that this challenge they put themselves to. Um, medical school is hard to get into in the United States. It's very competitive, and you have to work really hard to get into medical school. And I think it selects for people who are very motivated and are willing to put in the time and the energy to do that. And so you don't go through that unless you are really committed to seeing it through to the end. Typically, I think it also selects for people who are high achieving people who, like, there's a mountain in front of them and they feel the need to climb it, um so a lot of us, we just, it's like failing is not an option. Like, I have decided I'm going to be a doctor and I am going to be a doctor,
It's like it sounds like
um
consistent psychopath.
I know. I know. It is sort of yeah, it's a little bit masochistic, but I mean that's the type of personality that it takes to make it through, because it's kind of, residency anyways is kind of miserable sometimes. And I mean, you have to really be committed to making it through for that to make it. And, there's also like a light at the end of the tunnel. Like, being a doctor in the United States is a nice job. It's a prestigious job. It pays well. It is a much better lifestyle once you get out of training. And, some fields it's still many hours per week, but at least it gets better after you get out of training. And so, there's definitely a incentive to make it to the end, because the prize at the end is a good prize, it's a good career. And also there is a financial aspect, because medical school is extremely expensive in the United States. It's like, $70,000 a year, I think, is a pretty common tuition, which is a lot. And so for 4 years, you have hundreds of thousands of dollars of debt. Um, some students are lucky and their parents can pay for that or something, but most students take out loans, and they're high interest loans. And so it is, if you make it through all of your training and then you get a high salary as an attending, you can pay back those loans and it's fine. But if you don't make it, you still have all those loans, and then you don't have the high salary to pay it with, and it can become very problematic for people. So it's rare. Once you get into medical school, most people graduate, and it's even more rare for someone to not make it through residency. It does happen occasionally, but most people make it through.
Can residents and medical students go to any other fields that recognize their medical school education status? I mean, can they go to some sort of other than clinical work uh,
Yeah.
after graduating medical school? They can say, I've graduated medical school, I can work outside of the clinical work, just yeah, and try to pay
Yeah.
those bills.
Yeah, that's what people usually do if they do end up in that scenario where they either can't or don't want to practice medicine anymore. They can, there's certainly business opportunities. So that you can work as you can biotech or medical device innovation. I mean, there's a lot of opportunities in the business world for people who have medical training where you can still have a good career that uses your medical knowledge. It's just not maybe what people initially envisioned for themselves when they embarked on that path, but there definitely are opportunities and it
Mhm.
can be very lucrative. Like you can actually make a lot of money doing those things. So there are other opportunities.
Okay, and what is the role of students' activism in medical school and during residency? Do you have like active student groups or maybe some student councils or societies? Maybe they provide also some extracurricular activities. Do you have that?
Mhm.
And how common is that?
Yeah, there's a lot of student groups, many student groups, and some of them are just interest groups so that you can like meet other people who have this same interest as you and do activities related to that interest. But sometimes they are advocacy groups for all kinds of different causes. Um, and that, sometimes they go to the state capitol and advocate for some policy change, or sometimes they're just advocating for some change at the medical school, like in the medical school curriculum, for example, or sometimes they are advocating for patient rights or, some change for patient care. So it can, there's many different groups, but yeah, I mean, I think OHSU, I'm sure, has over 100 student groups. It's very, very
Mhm.
common for students to start those and participate in them, and most students are members of several student groups.
And how many students do you have in medical school that you teach in?
So in the medical school here, it's 150 approximately per class, and there's 4 classes. So I guess 600, but there's also some more because there's some people who are in PhD year. So some people do an MD, PhD combined degree program. Some people do an MD, MPH, Masters of Public Health. Some people do combined MD and like a research degree. So there's dual degree students um, around.
Mhm.
And then there's also sort of the like normal, just single track medical students. And so it might be slightly more than 600, but I'm not exactly sure what the number is.
Mhm. And you just said that some students they not only so here are two also questions to specify. The first one is that you said that some groups are created and exist for like pushing some ideas, maybe curriculum changes, some changes internally in the university. How do they usually do that? And do they face any punishment from the faculty members? Um, I mean, is that like what is the culture of those changes? Is that like some
Yeah.
protests or and how usually the faculty members react to that? Do they allow that to happen or they try to, like what's the process of that of
Yeah.
negotiation? Yeah.
So, in general, it is like very accepted for students to be advocating for things, especially at our medical school. We have, because we have so many students who do advocate for change all the time. It is like not a big deal and it is not seen as a threat, most of the time. And we sort of encourage that, because we want students who are going to ultimately like be leaders and be people who see something wrong and advocate for change in that thing. And so if it's like a really disruptive protest or something that, would be a different situation, but I've personally never seen that be the case. It's usually like very respectful, very reasonable advocacy from the students for some change within the university. And typically faculty and the leaders of the university, like the deans and the provosts and stuff, are open to working with students and discussing with students. And like, we can't always give them everything that they want, of course, but it is um, always open for discussion. And often there's some like compromise that can be made that keeps everybody happy, you know. And so I think it is generally a very collegial and respectful environment, and people are sort of happy to see students who care and who are taking time out of their free time to make the world a better place, you know. And um, even if we don't necessarily agree with them that like this one thing would be better if it was changed to this other thing, we'll still like sit down and talk to them about that, because at the end of the day, these students are paying a lot of money to be in this school, and we want them to be happy with their education, and we want them to have some control over their education. And so if they really feel strongly that like this thing is not the way it should be, then we will certainly listen to that and see if it's something that we can change.
So is it usually that they have like a group, and that group asks for a meeting, and where they share how they would like to change something, or is usually like um, protests, or maybe it's like upload some post online or request or send an email. In what form do they usually try to advocate?
I think it is, I think the most common either is like emails sent to leadership of that thing that they're trying to change, whether that be an email from an individual or an email from a group, just like raising whatever concern they have about it. And then that often leads to meetings, like either virtual or in-person meetings about that topic to discuss it further and try to understand exactly what their concern is and see if there's a way that we can address that that still maintains the elements that we think are important, but also addresses whatever they think is not ideal about it. Um, and so, yeah, I think it's often either an individual person or a group of people, like first sending an email and then having meetings with the leadership
Mhm.
of that thing.
Okay, and the second question about those active student groups, do they usually create, uh, sorry, it seems like, can you hear me well? Some freezes
Yeah,
probably.
I can hear you.
Okay, so
Oh,
do they usually have some events organized by students, or maybe some webinars organized by like student active students group, for example? They are interested in let's say in surgery, and they create some surgical club where they gather, they take chicken or chicken legs or something, and they sew them, or if that's common, or because of well-established simulating centers and well-built curriculum, it's something that is not that popular.
it's actually very popular for student groups to offer additional learning opportunities above what the standard curricula offer. So, for example, I'm the faculty leader for our emergency medicine interest group, which is like just a student group for anybody interested in emergency medicine. They can join, and the student leaders of that group will organize workshops for whoever wants to join, their skills workshops. So they'll offer us a suture workshop or an ultrasound workshop, or stuff like that, like skills airway workshops, skills related to emergency medicine. And it's usually geared towards students who are more juniors, so who are in like their first or early second year. They haven't gotten to the clinical phase yet, so they're eager for some hands-on stuff and want to start building those skills, but there's less of that in the curriculum at that point. If they want to show up to this workshop and like learn some ultrasounding or learn suturing or whatever, they can. So it's very common for there to be extra learning opportunities offered by these student groups for people who are interested.
Mhm. Okay. And you said that you are like a faculty member that is responsible for emergency medicine student interest group. Um, do those student groups are usually a part of do they have their hierarchy, like they are part of like student society council or student like, or they are attached to different divisions of faculty based on specialties, like a student active groups of surgery is has a like a surgeon faculty member who oversees them, and what is the structure?
Yeah, it's like what you just said. Like for the interest groups, each interest group in a field will have a faculty member from that field, typically, who is the leader. Every student, I'm pretty sure every student group on campus has to have a faculty sponsor. So there has to be some faculty member who's like willing to sort of like be responsible for the activities of that group to make sure they're not like going off the rails with something. And so, but yes, typically if it's related to a clinical field, it will be a faculty member from that clinical field. If it's not something related to a clinical field, like if it's like there's like the like hiking interest group, then
I
it can
see.
be
Yeah.
just whatever faculty member they know who likes hiking and is willing to do that as a volunteer. So
Mhm.
um, it just depends, but they do all have a faculty member. And then the student groups are also like under the provost office, so they have to register with the school in order to formally be recognized as a student group,
Mhm.
and stuff like that. So
Okay. And that was an really interesting topic because we have a lot of similarities there and quite a few differences. So that will be really useful to hear for us, for the team members. And another area of interests for us is educator training, and development. We are particularly focused on how to support faculty in improving their teaching skills and staying current with best practices. So, in this case, in the US, what programs or resources are available to help medical educators become better teachers?
so do you mean at our school specifically?
I think, yeah, maybe your school has some specific things, or maybe you can share, like if you know a perspective, general perspective. What are
Yeah.
the support systems for teachers?
So that I think it varies how much support each department provides for faculty development, which is like, faculty development encompasses how to be a good educator, but also encompasses how to be a good researcher and how to get promoted in the academic field and stuff like that. So it like encompasses more than just education, but it often encompasses teaching faculty how to be good educators. And so um, that some departments have optional activities for faculty that they can participate in that teach education skills. So, for example, our department has maybe 2 or 3 times a year, there's an optional um, little workshop that any faculty who want to can come to, and the people from the education section who have more formal training in how to be a good educator will sort of share tips and tricks on how to do good bedside teaching or how to give a good lecture or how to teach procedures or whatever it is. But that's all on an optional basis. So if faculty don't want to engage with that, they don't have to. Um, there's also university-wide resources. So there's um, a course that faculty can register for that is free if you're a faculty member here, called the Education Scholars Program. That is a year-long course that you attend once a week. It's like 2 hours a week, I think. And um, it teaches you a lot of education methods and a lot of information on how to be a good educator. It also teaches some research methods and stuff. And so that is, I think many universities have some sort of more formal course that faculty can go through, and then you get like a certificate at the end showing you have this extra level of knowledge about education. So that is, but that's also totally optional, and faculty don't have to engage with it if they don't want to. Um, there are national resources as well. Similarly, there are courses you can go, you can either, there's like free asynchronous, which means like you just do, it's like a virtual thing that you just watch lectures or you read articles or something on your own time. There's free courses like that that are available where you can just like do it on your own. There's a lot of that that's directed towards residents, especially teaching residents how to be good educators. Um, so um, there's a lot of those like free online resources available. And then there's also more formal courses that you attend virtually or in person that often cost money. That people can go to if they want to build up those skills, but it's all fairly optional. Um, I'm trying to think what else.
Mhm. And are there
Yeah, I mean, I think, yeah.
any specific certifications or like programs that are required, or yeah, that are required, like you have to go through them to be a teacher, or it's like, are they all optional?
Um, at our university, they are all optional.
Mhm. Okay, so what is the process of becoming a medical educator teacher? You have to be an attending, right? And then like to apply for the faculty or to the department where you want to work.
Yeah, so you have to, yeah, you apply to the department basically for a job, and at a large academic medical center like OHSU, it's competitive to get hired. So most people will have, um, some qualifications that make them well suited to that position. So often people do a fellowship and have some like subspecialty knowledge or some like
Mhm.
higher level of training than just the standard graduate of a residency, because it is a competitive um, position. But um, for example, I did residency and then I did my 2-year medical education fellowship. And then that fellowship allowed me to be competitive to get hired into this teaching job that I have now. So, in our department, most people who get hired have a fellowship. Not everybody, but most people.
And what other like advantages can you have that you will be competitive to the those who have a fellowship in medical education? You don't have, but you may have something else that would move you
Mhm.
upper.
So, a big one is for research. If you have grants that bring funding to the department, that can be a very powerful,
Mhm.
you know, tool to help you get hired. And so being a recognized researcher or having some research project that is grant funded already or is likely to be grant funded is definitely helpful to getting hired. Um, or sometimes people um, did something in residency that gave them extra experience or expertise in, sort of on a volunteer basis. They did a lot of extra work in some niche that now they've built up their CV in that niche, and it allows them to get hired into a more prestigious job. That's less common, I would say. It's more common that people go through sort of more of like a formal pathway, but certainly sometimes people just do and get experience in something on an informal basis, and that can also be helpful to getting hired. But I think in academia, the two most powerful factors are having a fellowship or having a promising research situation.
Mhm. And do you have to have scientific work aside of your clinical work and teaching as a medical educator in the United States? Like, is it obligatory to write some amount of scientific papers or to have some amount of publications?
So if you want to get promoted, then yes. So um, at our institution, there are three categories of achievement that they look at when you go for promotion. And you are incentivized to go for promotion because you get a raise when you get promoted, right? And everybody like wants to get promoted and wants to get a raise. And so in general, that is a path that people want to follow. So there's service to the department or to the university that is like volunteering to be on committees and leading initiatives in this or that, or sort of like any sort of like volunteer contribution to the department. Sometimes it's quality improvement work, but like something you do on a volunteer basis that is service to the university or to the department. That's one category. A second category is education. So you have to show some involvement or engagement with education of residents or students or whoever, and that can look like many different things. And then research is the third category, and that usually peer-reviewed publications are the highest valued, and grants, but also can be smaller things like case studies and poster presentations at conferences and stuff like that. And so to get promoted, you have to be either medium strong in all three categories, or you have to be very strong in two categories and like a little bit in the third category. So for me, I'll be eligible for promotion in like 2 years, and I'm gonna be very strong in education and very strong in service, and just like a little bit of research. And so it's not a lot. But you do have to do some to meet that low bar, and then you can get promoted to the next level. But if you're going to do less in research, you have to make up for it in these
Yeah,
other categories. And
I
you still have to do some, but it's not a lot.
I see. And what are those steps of promotions? It's a assistant professor.
Assistant professor. So really instructor is the lowest level, but most people start at assistant professor. And then the next step up is associate professor. And then after that is full professor. And in order, it's hard to get full professor. Many people never get it. They just stay at associate professor for their whole career, and that's fine. Full professor, you have to show a lot of engagement at the national level. So you have to do like national speaking, um, like national presentations. You have to be on national committees for your specialty, or I don't know. It's like involvement on the national level in your specialty, which can be hard, right? Like not everybody wants to do that. Not everybody who wants to can do that. And so full professor is hard to achieve. But for people who really go for it, it's cool. Like they become well recognized in their field.
And who sets this? Who decides if you're gonna get full professor or if you're ready for associate professor position? Like, is that internally in the medical school in
So
the
there's a committee, the promotions and tenure committee at the university who there's like a certain number of years you have to be at a rank before you can apply to go up to the next rank. So you have to be an assistant professor for 5 years before you can apply to be associate professor. But once you meet that bar, you submit, they have this like very, specific list of materials they need. They need your CV, your educator's portfolio. They need like letters from people who support you, stuff like that. You submit this whole packet of materials to that committee. They review all of your materials and then they make the decision, yes, we will promote you, or no, not this year. And if it's no, not this year, then you can work on it and apply again the next year.
Hmm. Okay, that makes sense. What about the evaluation of educators in terms of their teaching and the feedback collection and maybe improvement of skills? Are there any mechanisms on how faculty administration evaluates teachers and can give them feedback?
Yeah.
Oh.
Yeah, so students and residents both are asked to provide anonymous feedback to their educators on whatever thing they are engaging in. So students evaluate their like courses that they're in, residents evaluate the attendings that they work with in the clinical areas. Um, and it's optional, so they don't have to fill out well, I guess sometimes it's required. Sometimes it's required for students. Oftentimes it's an optional thing, but some percent of learners will fill out these evaluations forms. It's all anonymous so that they can feel free to be honest with people. And then attendings are provided with all of that feedback in like batches. So I think it's twice a year you get all of your evaluations from residents and all of your evaluations from students as a big batch. And you go through all of that information for the student stuff. The dean's office sort of keeps an eye and makes sure that the feedback is good. If there's some really consistent, really problematic feedback in there, they will be like, okay, we need to have a conversation about what's happening here. And then for the resident education, it's the chair of the department goes through your feedback with you twice a year and make sure that it's good. And if there's again, like some major problem, they'll address that with you. But that's how it's
Okay,
handled most of the
that's
time.
that's really cool to hear that there is a mechanism that yeah. So do you have I've heard from one of the professors that I've talked to in person here in Ukraine. He was on humanitarian mission. He said that his university has some sort of educators award that they have like once a year or something like this. And I think that it was like in each of the divisions, like in surgery, in internal medicine, or general one. I don't remember precisely, but do you have something similar? Maybe that's not for all medical schools, that common thing, but maybe you have some analog.
Yeah, I think it's very common that schools have teaching awards and like honestly there's at our university anyways there's many different awards that a faculty member can win. There's awards just within a section. So like there's like department and then within a department there's different sections. And so sections can award awards to people. The department can give awards to people. And then the school at large can give awards to people. And then there's also awards you can win from like national organizations and stuff. So there's different levels that you can get awards from. There's typically many awards that are available. And so you can if you're a good and they're for all different things. So there's awards for education, there's awards for research, there's awards for mentorship, there's awards for faculty development, like you help train your fellow faculty members. There's awards for like everything. But I think it's really nice because education it is often more work for less money than just being in private practice in medicine, and you do it because you love it and you find it really rewarding, but it sometimes feels a little bit like a thankless job and that you're putting in all this effort, and so it can be really nice to get some some award that recognizes some extra effort that you're putting into something. And so I think it's a really nice morale boost for faculty. And so I love that our institution has a lot of different awards that people can win. It also helps you with promotion. Like it helps you demonstrate, like I have done exceptional work in this thing, which I can demonstrate by showing that I won this award, which is given once a year for excellence in whatever this thing is. And so, yeah, there's many, many awards.
That's cool. And so you just touched the topic about motivation of medical educators, and you just, yeah, you briefly covered it, but it's a really interesting topic because in Ukraine, we feel as a group, we feel that the educators are really, like the motivation is really low. And we want
Mhm.
to work on that specifically to boost their medical. So that's where we were interested in awards, in stuff that is easy to apply, easy to
Mhm.
apply, but that can boost the motivation because obviously we
Absolutely.
don't have that maybe don't have enough resources to provide them with like salary um
Mhm.
salary benefits, but what are the motivation um of United States medical educators to be an educator? Like you can be a physician, right? But you somehow want to
Mhm.
go to the faculty to teach. Why?
Yeah. So a lot of people just love teaching, and that's like the part of their job that they enjoy the most, and they just want to do that more. And so they go into education. That's why I came into education. Other people love research and want research to be a part of their job. And if you want to be a researcher, then being at an academic institution is, makes a lot of sense. Um, some people, I mean it, and then so I think those are like the two main reasons is that people either want to teach, like they enjoy teaching, or they enjoy research. um but there's also extra incentives because it is, like I said, it is often more work and less money to go into academia. And so other incentives, it's generally prestigious to be at a teaching hospital, like at a university. It is sort of a seen as sort of a noble and prestigious thing. And so I think there's some sense of pride in working at a university as a physician and teaching because it's viewed positively by the community of physicians. There's also, like we talked about already, there's other small incentives that are like awards and things um that you can win that just make you feel good about yourself and make you feel proud of the work that you've done. And I think feeling proud of your work and valued by the people you're working with is one of the most important things for morale. And so um yeah, and I think I get a sense of, I feel more valued by learners than I do by patients sometimes, because patients in the emergency department are like, they're unhappy. They've been waiting for 4 hours. They are in pain. They're hungry. It's 2 o'clock in the morning. Like they're annoyed. You know what I mean? Like people are
Yes.
not always on their best behavior and not always so grateful for things. And I get it. Like it's a hard, nobody's not having a good day when they're in the emergency department. But so you don't always get that rewarding feeling from patients in emergency medicine, but I do get that from learners. And so for me, it's just like it's like a sense of self-worth that I draw from education that I don't get from other parts of my job. But there's also, and then, like I said, like the promotion structure is set up in a way that if you want to advance, if you want to make more money, you need to show that you're doing a good job in these areas. And so it incentivizes you to like be productive in those areas. But I think really the reason people go into education for the most part here is just that they love it and they want to.
And what is the the part of it that belongs to the community. Do you feel like you have a community at your faculty, like in your department with your colleagues? Do you have some sort of like community insights where you have like team building activities together or stuff like that?
Yeah, so that's sort of done mostly at the department level. And so I think some departments do it more than others, but we have um, every few months we'll have um, events where the department will just pay for us to go to a restaurant and just have a meal paid for by the department all together. And we can all just like hang out and chat and bond and have fun. We have faculty groups that are, like we have a women in emergency medicine group that often meets and does like fun activities. Like we'll do like wine tasting and we'll do, like painting or whatever, just like some fun activity to bond. Like we have the department definitely encourages bonding and will pay for bonding activities and stuff like that to help keep morale high because I do think that that contributes to morale. But I think so our department does that a fair amount. I don't think every department does that very much. So some departments do that a lot less. And so it varies. I forgot to say too, for some fields of medicine, this is less true for emergency medicine, but for some fields of medicine, if you are in a very specialized, like a very subspecialized field of medicine, you really can only practice at an academic medical center because your area of medicine is this very narrow area that
Mhm.
only a huge teaching hospital can support having a clinic for this one little thing. So some people in academia they're like not particularly passionate about teaching or research, but they're at an academic medical center because their clinical work is so specialized that they have to be at a teaching hospital because that's the only type of hospital that would hire someone who's that subspecialized, if that makes sense.
Yeah, absolutely. And do you have any problems with those kind of people who are like don't passionate about teaching, but they are a part of the faculty because of their scientific contribution or because of their like they are so narrow in the field that like they can work in that field and be a good physician, like a good surgeon, for example, but they are not that
Mm-hmm.
famous for, the teaching skills. So are there any mechanisms to like work with that kind of teachers?
Yes, I think that there's a problem every academic institution is that only a portion of the people it again varies by department, but um, that's where the feedback mechanisms come in, where someone doesn't have to be like the world's best educator to work there if they have other major contributions that they're making, but they at least need to be like within the acceptable range of education skills. And so evaluations from students and residents are very helpful for making sure that they are within the acceptable range
Mm.
um, for education. And if they go out below that acceptable range, then there is often um, some depending on how bad it is, like sometimes they'll just get some extra, um, they'll get a faculty mentor who is someone who is more familiar with good teaching methods and will meet with that person and say like, okay, how can we improve your teaching and give them some specific techniques and pointers to use, and that can be mandated by the chair, for example. Or if it's like a learner mistreatment issue, they can sometimes get restricted from having residents or medical students work with them for a while they meet with the chair or meet with other people in the department about, understanding like you cannot say these things. You cannot treat learners this way. That's not appropriate. Like most people don't need that. Most people are like kind people who don't have those issues, but every once in a while, every teaching hospital runs into someone who is mistreating learners in some way. And so those people will usually be prevented from working with learners until they get some remediation in that, and then can start working with learners again with a lot of oversight of their evaluations to make sure that they're treating people well. So I think depending on what the issue is, there is usually some intervention that happens that is triggered by evaluations that happens at the department level.
Okay. And to like come to the conclusive part of our interview, I would like to ask you about the mechanism. So I'm sure that some parts of the answer we already discussed, but just to like sum up, potentially that would be a good question about burnout in medical
Mhm.
educators and in, yeah, like medical educators who are physicians who need to teach students who need to, keep up with all of those complicated path on going up in their hierarchy of these professors, and also some personal life. So what are the, especially emergency medicine, where I'm sure that the rate of suicides and the rate of burnout is the highest in among all specialties. So any recommendations from you, from your experience, how to keep yourself fresh and ready to teach, ready to speak with patients, and not in a burnout situation?
That's hard. It's a hard problem to solve. Burnout is a big problem amongst all physicians in the United States, but especially emergency medicine. There are very high burnout rates. I think that burnout rates are actually lower amongst academic emergency medicine physicians because we often, I think people in academia like me often draw some value and like reward from that academic work that doesn't necessarily come from the clinical work. But for emergency medicine, what I usually tell students, because students ask me this a lot, they're thinking about going into emergency medicine, but they're worried about burning out. I'm like, yep, that is a legitimate concern um, in this field, but I do think there are ways that you can protect yourself from burnout, and the most important thing is to um, think about what your favorite part of your job is and make sure that you arrange your career in such a way that you get a higher dose of that thing in your job. And so um it is often some like extra thing that you add into your career that is more than just grinding through shift after shift after shift. And so for me, it's education. I like love education. That's what I enjoy. And so I added more of that into my career. But sometimes people love, you know, being in hospital administration, and so they can go that route. Sometimes people love ultrasound stuff, and so they can like get extra training in ultrasound and add that into their career. Sometimes it's global health stuff, and so they can add that into their career. But I think or sometimes it's like quality improvement, and they, really are passionate about like women's health needs in the emergency department, and they can like spearhead some project that addresses that thing. But you need to think about what in your job makes you feel a sense of self-worth from whatever that is. You need to arrange your career in such a way that you get a higher dose of that. Um, and that's not always easy to do, but I think for people who are able to do that, it is very protective against burnout, in my experience. That's usually what I tell students. I think for educators, like we've talked about already, I think people can definitely get burned out because sometimes it does feel like a thankless job and it's a lot of work. But I think having a institution and a department that focuses on high morale by having a lot of um, positive incentives for things, like many rewards for doing good work is really important. So even if they can't provide a high salary or something, it doesn't have to be monetary rewards, you know, it can be awards that have no monetary component, but it's just like feeling good about yourself. I mean, that's like a huge reward. And it can be you know, things like promotion to a higher level where you feel recognized for all of the work that you've put in. Um, it can be just the department chair, like recognizing you at faculty meeting if you've done something really great that month, like getting a shout out from your chair can be really meaningful. Like those small little things, I think for me personally, anyways, make a big difference because it's much easier to work hard at something that it's much easier to work hard at something that is hard if you are getting recognized and like thanked for that work. If not from the learners, then have that come from above. But I think that depends a lot on like departmental culture and the personality and priorities of the person who is leading the department. And so it doesn't always happen a lot, but I'm lucky at my department. It does happen a lot. So
Yeah, that's a perfect positive note. And I want to thank you for your time, first of all, that you spent in Saturday to share your experience, share your thoughts, opinions. And I'm really jealous of medical students that go through EM training, having this kind of mentor. So it's like honestly, I wish we had more and more people like you in our academia. So that's it, I think. Maybe you, except if you have something to add, because I didn't ask you. Maybe you have to have something that we did not cover, but you want it to be in this interview.
um I don't think so. I mean, I think we covered a lot. Nothing, no burning topics that we haven't covered yet.
Yeah,
But thanks for
that
asking.
was a really productive interview. Yeah, thank you so much. Thank you.
Yeah, thanks so
Thank
much for, you know, letting me blab on and for listening what I have to say.